And you are.
Okay, we are back. This is Senate Health and Welfare, and we're continuing to go through bills that we have in committee. The next two bills are Senate bills, S-242 and S-193. And I think the interest is to see what, if anything, of these bills we could add into our House bill on TDMs. Yeah, thanks. So the first bill, I'll just make a real quick intro, is an act relating to prescription drugs dispensed by a health insurer designated pharmacy for administration to a patient in a healthcare setting. So for me, the bill is the essence of the bill is patient safety and making sure that any drug dispensed to a patient that then the patient would have to take to the clinic for use, that any of those drugs, you know, it could be a cancer infusion, I don't know what it would be, but it could be a cancer infusion that's delivered to the patient's home, and then the patient would take it to the clinic for use. And my concern is, you know, suppose the drug sits on the front step for a period of time, or the patient doesn't know how to care for it properly. So it's just a matter of making sure that the chain of custody for the drug is maintained and that patient safety is ensured. So that's how I see the bill. And the general explain it a lot better.
Is this white bag?
Oh, this
Yes.
is white bag, brown
Yes, brown bag
bag.
and
I
white
should have
bag.
said that, right? This is white bag, brown bag.
Exactly.
Yeah.
Which is sort of a, you know, a jargon term, I think, that's used to describe brown bagging being where it's at the patient's, you know, the patient has the drug and the patient has to get the drug from a particular pharmacy and then bring it to the doctor's office to have it administered. White bagging is when it goes from the designated pharmacy to
Right to the
provider to be administered to the patient. And it sounded like there were some insurers that were designating which pharmacies had to be used for these, and that was the process to be used. So this language would make that less mandatory on the providers and patients. All right, so this would add a new section in Title 8 in the Insurance Chapter about prescription drugs dispensed by health insurer designated pharmacies for administration to parents in a healthcare setting. First, we have some definitions. So definition of healthcare professional is someone licensed to practice medicine as an MD or a DO, so an allopathic physician or osteopathic physician, someone licensed as a naturopath, someone licensed as a physician assistant, and someone licensed as an advanced practice registered nurse. That's who we mean when we talk about healthcare professional in this bill. Healthcare setting means a healthcare professional's office or a hospital or clinic where the healthcare professional practices. Health insurer is our fairly broad definition in from Title 18. So this would say first that a health insurer shall not, by contract, written policy, or written procedure, it shall not require that a pharmacy designated by the health insurer dispense a medication directly to a patient with the expectation or intention that the patient will transport the medication to a healthcare setting for administration by a healthcare professional. So an insurer cannot require that by contract. But in subdivision 2, a health insurer may enter into an agreement with a healthcare professional for this to happen, under which the pharmacy designated by the health insurer dispenses one or more medications directly to a specific patient for the patient to transport to the healthcare setting for the healthcare professional to administer to the patient. So B1 says health insurer cannot require this by contract, but they can enter into an agreement with a healthcare professional. So the healthcare professional would be agreeing to this as opposed to having it dictated by the insurer. Subdivision 2B says that a health insurer that enters into an agreement pursuant to this subdivision 2, so this voluntary agreement, must attest to the Department of Financial Regulation, DFR, in a form and manner determined by DFR that, and then there's a list of things that the insurer must attest to, that the insurer provides an expedited patient-specific exception process for cases where the healthcare professional certifies that it is unsafe for an individual patient to receive medication directly from a health insurer designated pharmacy. So there has to be a carve out available for specific patients. The health insurer designated pharmacy provides for same-day delivery of medications. So again, this is what the insurer is attesting to. Their designated pharmacy provides for same-day delivery. That their designated pharmacy is accredited by a national pharmacy accreditation organization. That their pharmacy has the ability to deliver medications to the patient's home in a clinically appropriate dosage and a ready-to-administer form. That their designated pharmacy uses cold chain logistics or other means to ensure that each medication remains at the appropriate temperature throughout all stages of supply, storage, and delivery. That their designated pharmacy provides a medication's pedigree to certify to the healthcare professional that the medication was handled appropriately throughout the supply chain. That their designated pharmacy demonstrates expertise and reliability in risk evaluation and mitigation strategy that complies with the U.S. Food and Drug Administration reporting requirements, and that the health insurer or their designated pharmacy or both make access to a pharmacist or nurse available 24 hours a day, 7 days a week. So again, this is the potential for a health insurer to enter into an agreement with a healthcare professional where the medication goes directly to the patient for the patient to bring to the doctor's office. Now on page 4, there's similar provisions, but this is the direct to healthcare professional. So again, a health insurer shall not, by contract, written policy, or written procedure, require that a pharmacy designated by the insurer dispense a medication directly to a healthcare setting for a healthcare professional to administer to a patient. But then in C2, it allows a health insurer to enter into an agreement with a healthcare professional under which the pharmacy designated by the insurer dispenses one or more medications for a specific patient directly to a healthcare setting for the healthcare professional to administer to the patient. So again, can't require it, but it can be an agreement between the insurer and the healthcare professional. And yes,
So what happens if an insurer doesn't
that's what.
enter into an agreement?
Well, it's okay, it's a may, so they may enter into an agreement. So they're prohibited from mandating it
Yeah.
to the healthcare professional, but they are allowed to enter into an agreement, but they do not have to enter into an agreement with the healthcare professional.
Okay, so they could continue to do what they do if they're sending it to the patient now, they could continue to.
Right, there can't be I think, as I understand this issue, it was a concern raised by healthcare professionals that this was being required of them through the contracts or through other communications from the insurer. So this is taking it out of that one-sided insurer gets to decide whether this is what happens or not, but it would allow these arrangements to be entered into by two parties, the insurer and the healthcare professional.
Okay, so going back to Senator Lyons' concern about the safety of the drugs, how does this affect that and change it from what is happening now?
I think that's a big question to hear from the providers about, because I don't know the specifics of what their arrangements
We'll get
look like
testimony on
now.
that, yeah, if it helps. Yeah.
Okay, so on page 4, and again, health insurer cannot require this, but can enter into agreements with healthcare professionals to set this up. So this is the white bagging where it would go directly to the healthcare setting, and then the healthcare professional would administer it to the patient. I think the alternative is that the healthcare professional in the healthcare setting procure the drugs, however they have otherwise been doing it, to administer to the patient there. So having the healthcare professional have the choice of pharmacy and process rather than having this requirement of a particular insured designated pharmacy delivering the medication to the patient or to the healthcare professional for use in a healthcare setting. And similar to what was in subsection B, here we have in subdivision C to B that a health insurer that enters into an agreement with a healthcare professional under this subdivision must attest to DFR in a form and manner determined by the department that the health insurer provides an expedited patient-specific exception process for cases where the healthcare professional certifies that it is unsafe for an individual patient's medications to come directly from the insurer designated pharmacy, that the designated pharmacy provides for same-day delivery of medications from the pharmacy to the healthcare setting, that the designated pharmacy is accredited by a national pharmacy accreditation organization, that the designated pharmacy has the ability to deliver medications to the healthcare setting in a clinically appropriate dosage and in a ready-to-administer form, that the designated pharmacy utilizes cold chain logistics or other means to ensure that each medication remains at the appropriate temperature through all stages of supply, storage, and delivery, that the designated pharmacy provides medications pedigree to certify that it was handled appropriately throughout the supply chain, that the designated pharmacy demonstrates expertise and reliability in risk evaluation and mitigation strategy that comply with FDA reporting requirements, that the insurer or its designated pharmacy or both make access, in this case, just to a pharmacist available 24 hours a day, 7 days a week, and this one is different, that the health insurer offers payment policies that reimburse for office-administered medications at the same rates, regardless of whether medications were obtained from a pharmacy designated by the insurer or by the healthcare professional or healthcare setting, which payment shall include the costs for the healthcare professional or healthcare setting to intake, store, compound, and dispose of the medication. Finally, on page 6, a health insurer shall not, by contract, written policy, or written procedure, require first, sterile compounding by a healthcare professional in a healthcare setting without providing reimbursement to the healthcare professional for that service, or require a medication with a patient-specific dosage requirement to be based on lab or test results on the day of the patient visit to be distributed from a health insurer designated pharmacy to a healthcare setting for administration. So just to put those in a little bit more plain language, in D1, health insurer can't require the healthcare professional to do sterile compounding without paying the professional for doing that compounding service, and they can't require a sort of very patient-specific medication to be distributed from the health insurer's designated pharmacy if it is to be based on lab or test results on the day of the patient visit. So if it needs to be kind of now, it can't have to go through this insurer designated pharmacy distribution process. And subsection E allows, but does not require, allows a health insurer to offer coverage for, but health insurer shall not require the use of a home infusion pharmacy to dispense sterile intravenous drugs prescribed by a treating healthcare professional to a patient in the patient's home, or an infusion site other than the treating healthcare professional's office or a hospital or clinic at which the healthcare professional practices.
Okay,
So some things that they can cover, but they can't require use of.
so just looking at the two sections, one section related to the pharmacist and the other section related to the healthcare professional. Can you give us kind of the broad look, and especially since Senator Hart has just sat down?
Sorry,
We're on 242.
Okay. So yeah, so I think the broad view of this bill is prohibiting health insurers from requiring, but allowing them to enter into agreements where both sides would have a say with healthcare professionals about using an insurer designated pharmacy, a pharmacy picked by the insurer, to either deliver medications to the patient's home for the patient to bring into the healthcare setting to be administered by a healthcare professional there. So that's the brown bagging idea. Or that same process, but to have the designated pharmacy dispense the drugs directly to the healthcare setting where the healthcare professional is going to administer them. So this can't be just the insurer deciding this is how it's going to work, but if the insurer and the healthcare professional want to agree that that's how it'll work, then they can enter into that agreement. And there's a bunch of parameters for attestations to DFR that a bunch of precautions have been met.
Currently, do insurance companies designate pharmacies and do this?
I am assuming at least somewhere this is occurring, or this proposal would not have been brought
Okay.
forward, but I do not have independent knowledge of how that works.
Well, we'll have.
Is there,
Yeah, we'll have the
okay,
insurers and the providers. And
is there anything in it about the patient being involved in the decision, or is it just the provider and the insurer get to decide where the patient gets their medication?
It's really about who decides which pharmacy it is. That would be, and I think there's likely some role that you'll want to hear from the providers for the provider working with the patient to determine what the appropriate route is.
Okay.
So if yeah, I think it may be medication and patient specific. But I don't want to speculate much.
Okay.
Okay. So, I mean, the thought is we'll get some testimony in on this as we're getting testimony on the PBM bill. The thought is because it's an S bill, we'll try to integrate this in with 353. You know, all things being acceptable. So, so good. So we'll just, why don't we just go ahead to
193.
193.
Okay.
And this is this is a set of recommendations that has come to us from the Green Mountain Care Board Prescription Drug Advisory Committee. And so we put them all together into this bill to introduce them, and there may be things here that fit with what our interests are or not. So this is, you know, it's the same idea. It's an S bill, but it's prescription drugs. And so we'll look at what's here and go forward.
Yes, that's exactly right. So this came from the Green Mountain Care Board's Prescription Drug Technical Advisory Group, and they had some recommendations, some of which would require more looking into, and so this would really direct that work to occur. S-193 is an act relating to strategies for reducing prescription drug costs for Vermonters. Section 1 would direct the Department of Vermont Health Access, DVA, to consider and evaluate options for addressing Vermonters' high out-of-pocket costs for prescription drugs, including expanding eligibility for the Healthy Vermonters program and increasing the number of drugs that the program makes available to enrollees at lower prices, modifying the Healthy Vermonters program, or adopting a 340B contract pricing program, or both, to provide more Vermonters with access to prescription drugs with limited or no cost sharing requirements, and expanding eligibility for Vermont's Medicare savings programs. And that report would be due by January 15th to this committee and committees in the House, with their findings and recommendations, including the advantages and disadvantages of those options and any other options the department identifies to address out-of-pocket costs for prescription drugs, along with a cost estimate for each option. Section 2 would have the Green Mountain Care Board, in collaboration with the Department of Financial Regulation and the Office of the Attorney General, examine issues relating to the regulation of private pharmacy discount programs, including pharmacy participation fees, the sale of participant data, and prescription drug manufacturer coupons. And by January 15th, 2023, the board would recommend to this committee and the House committees whether and how these programs could be used to minimize impacts on pharmacies and maximize their usefulness for patients while protecting patient privacy. Section 3 directs the Agency of Human Services to coordinate with a resource center in this state to provide information to the public regarding prescription drug financial assistance programs, including state prescription drug programs such as Healthy Vermonters, Medicare savings programs, prescription drug manufacturer programs, sliding scale fees available through the federally qualified health centers, and hospital charity policies. And finally, Section 4 would direct the Department of Health by January 15, 2023, in consultation with the Board of Pharmacy, to provide recommendations to this committee and the House committees regarding the statutory changes needed to remove barriers to pharmacists making therapeutic substitutions for purposes of reducing prescription drug costs to consumers. So as opposed to generic substitutions where there's a law, already a law, and they can just make a substitution. These are ones that take a little bit more discretion.
So it's really a set of working groups to identify savings.
Exactly.
But I know the advisory group worked very hard on this, so we probably should hear what they have to say.
So an advisory group is just setting up more advisory groups.
Would this be a place to consider wholesale drugs? The whole idea of setting up purchasing drugs from wholesalers, the state purchasing drugs from wholesalers.
We could ask that question. It may, I don't know whether it may fit in one of these yet. The discount.
Just
I'll take it back on that.
In the third one, section 3, the Medicare savings programs.
Yep.
That's not the Medicare supplemental
No,
insurance and all that.
no.
This is what are referred to by acronyms as QIMBY, SLIMBY, and QI. These are programs that help lower income Vermonters afford the Medicare program. So it helps them buy it
Okay,
for the parts that cost.
okay.
It's part B.
That's okay. All right,
So
so
interested to know, yeah.
well, we'll think about this one. There may be something here we'd like to add into the bill as well. We'll have the advisory, someone from the advisory group come in and
Yeah.
they'll help us a little bit, what their thinking is. Okay, good. So so I'm gonna suggest that the white bag, brown bag, if the committee is okay, that we can attach that to 353, and then as we're taking testimony on 353, we can ask, for example, when insurance companies come in on one, they'll also have the whole, all of it right in front of them. We can do that. Is that okay? Can we do that?
Yeah, I just need to understand it since I missed most of it.
Gotta get your brown bag.
Yeah,
Okay, yeah, we'll do that.
I have props.
Yeah.
Right, your own lunch, bring your own lunch.
Okay, so, Jen,
Yes.
we have 655 that's passed by the House. We wanted to go through it a little bit with an eye to markup.
Right, so we had started to go through it the other day, we stopped on page 10.
That's what I thought.
Hopefully left myself a little line, so
Lauren Hibbert is not here today, but we'll go through it.
okay,
Did we make any suggestions for change up to?
not so far, I don't believe, I don't think we've made any.
Let's do this. I want to stop at this at around 10 after, and then I've got a couple things I want to talk to the committee about, and then we'll take a break before we're on the floor. Okay.
All right, so now we're on page 655, this is the telehealth licensure and registration system. And we were looking at the provisions of the new chapter that would go in Title 26, and we are now in the middle of page 10 of the as passed by House version, looking at the scope of practice and standard of practice. So this section says that in order to be eligible for a telehealth license or telehealth registration, a healthcare professional must hold a license, certificate, or registration in another U.S. jurisdiction that authorizes that provider to engage in the same or a broader scope of practice as healthcare professionals in the same field are authorized to engage pursuant to a license, certificate, or registration issued in accordance with the relevant provisions of this title. And I think Lauren talked to you a bit about that last time.
Right. So my question about this one is, when it says or broader scope of practice, does that mean the broader scope of practice lies with the state in which the healthcare professional held their original license, or does that mean that the broader scope of practice is in the state of Vermont?
So this is saying that in order to be eligible for the license or registration, their out-of-state license, certificate, or registration has to enable them to provide the same scope of services or a broader scope of services as that same profession would here, and then we're going to tell them what they can practice in this
Okay.
next piece. So in subsection B, it says, while practicing in Vermont using telehealth, a healthcare professional holding this telehealth license or registration must practice within the scope of practice established in this title, so in Vermont law for that profession. So even if they could do more in their other state at whatever license they hold there, in Vermont, they will be limited to just what somebody here could do. And practice in a manner consistent with the prevailing and acceptable professional standard of practice for a healthcare professional who is licensed, certified, or registered in Vermont to provide in-person healthcare services in that healthcare profession. So they have to practice like a Vermont provider would, who provides in-person services here. Okay. Then we get to records. A healthcare professional holding a telehealth license or registration must document in a patient or client's medical record the healthcare services they delivered using telehealth in accordance with the same standard used for in-person services, and shall comply with the requirements of 18 VSA sections 93, 61, and 62. Those are our existing statutes on healthcare professionals practicing using telemedicine, store and forward, and audio only, to the extent applicable to the profession. And records, including video, audio, electronic, or other records generated as a result of delivering healthcare services using telehealth, are subject to all federal and Vermont laws regarding protected health information. Not making any changes, just reminding everyone those apply.
So, and reminding us that telehealth is telemedicine is the overarching
Telehealth is the overarching term.
Telehealth is the overarching definition.
Right, and that's the term that we have defined
Yeah,
in the bill to mean telemedicine, store forward, and audio only.
so
that
it includes audio only,
does include
which
audio.
does put some responsibility on the part of the professional to save that recording of that.
You're not supposed to record
I'm just
call under our laws. You're not allowed to record the call. But if there are certain recordings that are made, I don't know what, if you have a patient sends a recording of the sound of their cough,
right.
that would be saved as part of their medical record.
Is there a distinction that we have in rules or will be made in rules for that? Or is that something left to the professional discretion
About what? Rules?
of what you record on the audio only?
Well, for the most part, there will not be recordings made, but if it is appropriate in a particular,
Medically appropriate and medically necessary. No.
right, I mean, I'm trying to think of something that might be recorded, maybe an image or a video of a patient walking in order to show them,
Right.
things that they're doing with their body that the professional is going to help them address.
A rash.
But the statutes on telehealth and audio only specify that nobody can make a recording of the visit. So it wouldn't just be a recording of
The whole
the
thing,
whole thing.
but you could get the call.
But I'm just trying to think of examples of
Yeah,
something
no,
that
I
somebody
get
might
It's
use to make.
audio, yeah, because my daughter had to take her phone and for the orthodontist and do the inside of her kid's mouth
Yeah,
to send to the orthodontist.
Right.
I always wondered how teledentistry worked.
There's different ways. There's also ways where the treating provider is on the screen and the hygienist is in the room with the patient and is following directions. That came up while we were working on the telemedicine stuff.
okay, this is helpful.
All right, section 3057 is talking about the effect of disciplinary actions that relate to the out-of-state license, certificate, or registration. So first it says that a healthcare professional shall not obtain a telehealth license or registration if the healthcare professional's license, certificate, or registration to provide healthcare services has been revoked or is subject to a pending disciplinary investigation or action in any other U.S. jurisdiction. And similarly, a healthcare professional who holds a telehealth license or registration must notify OPR or the board within 5 business days following a disciplinary action that places a warning, reprimand, condition, restriction, suspension, or any other disciplinary action on the professional's license, certificate, or registration in any other U.S. jurisdiction, or of any other disciplinary action taken or pending against them in any other U.S. jurisdiction. So if there's something going on with their out-of-state license, registration, or certificate, Vermont wants to know, and they're not getting a telehealth license or registration if there's something negative going on in one of those other states.
But it's up to the person applying to,
Well, that's also, I believe that's also something in requiring verification of licensure and good standing in the other state that OPR, Board of Medical Practice, would be required to be submitted. So would be some follow-up by OPR report as well. Section 3058 says that a healthcare professional who holds a telehealth license or registration is subject to the laws and jurisdiction of this state, including those two sections on healthcare professionals delivering services by telemedicine, store and forward, and audio only, and laws regarding prescribing, health information sharing, informed consent, supervision and collaboration requirements, and unprofessional conduct. Section 3059 gives exemptions from registration and licensure requirements. It says that a healthcare professional is not required to get a telehealth registration or license solely to provide consultation services to another healthcare professional regarding care for a patient or client located in Vermont, as long as the consulting healthcare professional holds a license, certificate, or registration to practice the profession in one or more U.S. jurisdictions, and the consultation is based on a review of records without in-person or remote contact between the consulting healthcare professional and the patient or client.
Can I ask about that? So this would be maybe a neurologist in Vermont wants to consult with a specialized neurologist in Boston, and they can share medical records with the patient's permission. But if that specialized neurologist in Boston, assuming they're licensed in Massachusetts, et cetera, but if that specialized neurologist in Boston were to have a telehealth appointment with the patient, they would have to have a license to do so.
Yep.
Okay.
Yeah, so if it's just healthcare professional to healthcare professional about a Vermont patient, that doesn't trigger the telehealth licensure or registration requirement for that sort of one step removed provider. But if they're going to have any interaction with the patient, including remote contact, then they would need to have to get Vermont license, at least telehealth registration or license.
Got it.
Venue, so venue for civil action initiated by the office, the board, or patient or client who received telehealth services in Vermont from an out-of-state healthcare professional holding a telehealth license or registration, be in the patient's or client's county of residence or here in Washington County. And finally, 3061 allows OPR and the board to adopt rules to carry out the purposes of this chapter, including in consultation with the appropriate boards and advisor appointees for professions regulated by OPR, rules regarding any profession-specific requirements related to telehealth licenses and telehealth registrations. Section 2 is the provisional licensure section that you, I think, heard about from Lauren Hibbert, and this is provisional licensure for, and this is any profession, not just healthcare professions, regulated by OPR. And this would add a new section entitled Title 3 on provisional licensure that allows the director of OPR to issue a 90-day provisional license to an individual who has completed an application for full licensure, and either their eligibility for licensure is contingent upon acceptable verification of licensure from another jurisdiction. You've heard sometimes that can take a long time. Or their eligibility for licensure is contingent upon completion of a background check, and that hasn't come through yet. Or they're an active duty member of the U.S. Armed Forces assigned to duty in Vermont, or that person's spouse. A provisional license is based on a voluntary agreement between the applicant and OPR to expedite the applicant's entry into the workforce, in which the applicant agrees to forego the procedural rights associated with traditional licensure in exchange for getting a provisional license pending final determination of their license application. We're giving up some process in return for getting a quicker provisional license. A provisional license can only be issued to an applicant who can attest to material facts consistent with the requirements of full licensure, including their standing in other U.S. jurisdictions, their criminal history, and their disciplinary history. And an individual to whom a provisional license is issued must expressly agree that OPR can summarily withdraw the provisional license upon discovery of any inconsistency or inaccuracy in the application materials. An individual who is aggrieved by denial or some summary withdrawal of a provisional license would have as their exclusive remedy the right to have the individual's application for conventional licensure determined under the usual process. And this would allow the director of OPR to extend a provisional license beyond the initial 90-day period if that reason for issuing the license has not been resolved. They're still waiting on the verification from the other state.
So the usual process
Yes.
is,
Usual process is the full licensure process that's spelled out in Title 3 and or Title 26.
but we don't need to say that. Okay,
No, that's the
Yeah.
conventional license.
got it.
Okay. Section 3 is an appropriation. This appropriates $360,000 from the general fund to OPR in FY23 to develop and implement the telehealth licensure and registration system. Section 4, which is the telehealth licensure and registration system, will take effect on July 1st, 2023. If you remember in H654, you created kind of an interim registration process for telehealth that ends on July 1st, 2023. So this new one would take over then, except that OPR and the Board of Medical Practice have to begin the rulemaking process prior to that date so that their rules are in place on July 1st, 2023. The provisional licensure provision takes effect on passage, and the appropriation would take effect on July 1st.
Questions?
Do you know if this money is in the budget?
My understanding from Nolan, I think Nolan was checking, was yes, it is being accounted for in the budget. It is not, but I think at least for now, and this bill would need to go to the appropriations committee anyway, but at least for now, it's not being carried as specific language. So this is where the appropriation language would live, but the money is being reflected in the totals in the budget.
Got it, okay.
Yeah, we'll see that when we go through the budget on Thursday. We know what it's on Thursday. All right, wanted that umbrella. Okay, so committee, here's my suggestion. We have this on the agenda next week on Wednesday. And so just go through it over the weekend when you get a minute, go through the bill and see if there are any specific sections or wording that you'd like to recommend changes for. And if not, I think we can probably move pretty quickly on this one.
Yeah, we haven't heard any concerns, or like Lauren didn't bring anything up that she found, and you haven't seen anything that you think.
But no
I'm
one's
not aware
coming.
of anything. I think the only thing was just flagging whether the money is being
Yeah.
carried in budget. And my understanding from Nolan is yes.
Yeah, so if you hear it, if you hear from someone,
It'll go to finance.
Yeah, right,
because
yeah.
of the-
it's gotta go everywhere, so it's better to get it started, yeah. And we haven't really heard from anyone. If you do hear from someone who needs to be in here and give us information, we'll do that, but I think we can try to move this along. Okay, and then on.
I'm so glad it's Friday.
Huh?
I said, I'm so glad it's Friday. I'm really tired.
I know, everybody's tired, and it's
That's
just,
what I had for breakfast, Josh. It's
Oh.
terrible, isn't it? I mean, it's good, but it's also.
Terribly delicious.
I wanted to.
this
wanted
is
to
a
talk
health
about-
and welfare committee. This is a
I know.
health and welfare.
We're having chocolate chip cookies for breakfast.
There's gotta be walnuts in there, that would be.
This is raisin oatmeal. so-
Oh, that's better than what I
Raisin
had.
really.
That sounds breakfasty.
Yeah, exactly.
Okay.
A bowl of oatmeal and baked corn.
All right. Yeah, good apricots and walnuts. Okay, all right, so here's, Jen, thank you. I think that does it for going through some bills, and we have a full week next week coming up on some of the bills we've been looking at. And if we can have the white and brown bag attached to H 353, then when folks come in to testify on 353 on Wednesday, we'll be able to pick up testimony, and we're gonna have to add other testimony on that one, obviously. Then we've got the home and community-based services coming up, hearing aids, and then hopefully on Wednesday, we can also vote, or at least move page 6555. Thursday, we're gonna be looking at the budget. And on the budget piece, here's what, as I mentioned, I think to a couple of you, if you have had requests from folks about the budget, like I just got a request from Mike Fisher. I think we don't have the luxury of time to take full testimony on all the requests that we're getting. So what I'm gonna say is, if you have a request, get it in writing and get it to Aaron, and he will print these out for us to have at our desks. And then we will have a discussion. We'll be able to look at all the requests that we're getting in addition to all the work that we've done in our bills. So that's my please request is, if you have folks coming to you, like I had the HIV folks coming in with a request, and there are others. We're gonna try and consolidate all of that into a single list, a single place, so we can look at it together. And then, is this about the budget?
No, it's about one of the bills.
Okay, well, we'll do that in a minute. Okay. And then, so that one, so Nolan is putting together a little spreadsheet for us on everything that we've done in our bills. And then we will have all the other interests. I know we've got childcare that we haven't taken a lot of testimony on this year, but we do have some issues related to that. We have HIV folks. I've got some folks on I think on opioid stuff, and then our healthcare advocate. And I don't know what else?
Recovery centers, you talked about recovery centers.
Recovery centers, right? I did have a request from recovery
Food
center.
bank was in here, yes.
Who was it?
Food bank,
And the food bank, right? So
child integrated services.
CIS, we have all of those things. So that, try to get whatever you have that you've gotten either by email or you have in writing, get it to Aaron, and then we can all have it to look at together.
Should we send it to Aaron and Nolan? So Nolan has a list too,
Sure.
a spreadsheet.
Yeah,
Okay,
yeah.
I'll do that over the weekend.
Terrific.
Um,
And
Okay.
almost,
sorry.
we won't forget you. Okay, so we did that. And then one other thing, two other things. So the economic development bill that just came over from the House, the workforce bill, the House Healthcare Committee worked weeks on what's in there for healthcare. So I am going to suggest that our committee, I don't know what the timing is on that bill there, but it's gonna have to be some work done in various committees and with appropriations. We're gonna pick up that chunk on healthcare workforce, and we're gonna look at it in this committee. Did you run? Yeah.
I drafted it, so.
Yeah,
That's great.
it's huge. They did a lot of work, and I think, as we do sometimes, and there's no credit given, but I think we need to make sure that we look at what they've done and affirm it or modify it as we think best. So that one is important to us. Then last thing I'll say, and then if you had a question about a bill, will be the last thing I say. Just please read the bills that we have coming up and that we've been looking at, because we want to try and move pretty pretty efficiently through
April.
some of this stuff. Yeah, it's a lot. Senator Hardy.
Did you, thank you, Madam Chair. Did you mention 464, H 464, the reach-out bill?
I didn't mention it, but we are gonna work on it,
We are.
and that has an appropriation in it.
Yeah, I know.
And
so
I think that's already on Nolan's list. So I don't think it's on the agenda for next week, but we can, if we have a room, we might pick it up and go through it.
Is Katie?
Yeah.
Yeah,
Yeah.
that would be good. I've gotten stopped in the hallway a couple times about it.
Oh,
I'm like, oh, I think we're gonna do that, so it'd be nice.
Oh, yeah, we're gonna try and do as much as we can, and that one, and because it's got an appropriation in it, I think it's base funding, it goes forward, so we'll have to fit that into everything else.
Okay.
It's on the agenda for Thursday.
It's on the agenda for Thursday.
In 10 seconds
Oh,
or
yeah,
less,
there
can
it
someone
is.
tell me what a reach-up program is?
Welfare,
Okay, thank you.
That's what it used to be called.
Right, yes. And
Okay.
it's funded with the federal temporary assistance to
Right,
needy
it
families.
has work
TANF funds.
requirements, it has finance,
It's
we learn
for
how to manage your
really important.
finances, it's got a lot of good
yeah,
stuff.
it's work requirement, there's a lifetime limit.
Yeah, it's a time limits,
The
And
bill
they haven't
gets,
up the money.
the bill gets out rid of that.
I think a family of four is getting somewhere around $800 a month.
right, so we've got 464 on Thursday after we look at the appropriations.
James tried it.
You do that.
Yeah. And pay rent.
Okay, take a
Yes.
break, I think, is there anything else?